My name is Jenny, and I'm a research assistant with the Addictions and Concurrent Disorders Lab at UBC, and I will be your moderator for this workshop. The session is called The Kids Aren't All Right, Youth Intensive Case Management in British Columbia. And we're very lucky to have two experts in the field, Fernanda and Lorna, present this workshop for us. And Fernanda is a family nurse practitioner working in Victoria and is a current BC Center in Substance Use Addiction Nurse Practitioner Fellow. And Lorna is a social worker and has been working the past 15 years for youth who use drugs. And I will now pass the floor to them for further introduction and to begin the workshop. Thank you, Fernanda and Lorna.
Thanks, Jenny.
Thank you. Okay, well, Jenny, you did our first job for us. So we just presented the slide and who we are. Yeah, like I said, I'm Fernanda. I'm a nurse practitioner here working in Victoria, and also a current BCCSU fellow.
And I'm Lorna, and I'm a social worker here in Victoria with the Youth Intensive Case Management team.
We want to start off with the land acknowledgement. So we want to respectfully acknowledge that the land in which the conference, so a lot of folks might be joining today, is located on the ancestral traditional territory, the unceded, meaning stolen and never given up territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. Lorna and I right now are sitting in a different territory where we want to respectfully acknowledge that the land on which we are gathered today is the unceded and traditional stolen territory of the Wasanic, Lekwungen, and Songhees people. There's something that I recently talked about this that sociologists talk about a lot. Like it's easy for us to see when we're swimming against the current. So, I'm brown, I'm a woman. And so it's easy for me to kind of pick up on when there are oppressive movements. And we have both, Lorna and I have both been working in healthcare for over a decade, both of us. And we also live in the society that is colonial and racist, and specifically anti-Indigenous. So I think a part of where we see when we swim with the current is acknowledging that we've been shaped by these systems. And so part of that is the very start is even just acknowledging this stolen land in which we're gathered.
In regards to disclosure of conflicts of interest, we have none. So thanks for joining us today. Just to briefly go over the outline, we are going to be talking about assumptions around youth and substance use. We're going to talk about impacts and intersectionalities. Then we're going to talk about what is a youth intensive case management team based on our experience in being with one of the first teams in BC. We're going to move into things that we've learned in our time with the team and then future considerations.
Okay, starting off with a fair assumption from which to work. People of all ages who use substances are treated as though they are less deserving of care, especially Indigenous people and people of color. This is structural stigma, and this is the part that which we all partake in. And so when somebody comes into a system, whether that be, policing or healthcare or whatever the system might be, these are the structural stigmas that we put onto that person. And that's not actually a subjective comment. Those are objective measures. In 2022, there was a cohort study, an observational study done looking at Indigenous people in Vancouver who were engaging in sex work and looking at different experiences that contributed to unsuccessful substance use treatment attempts. And they found that the experience that had the highest number of unsuccessful treatment attempts was police harassment. So to acknowledge that our structural stigma has a lot of power. The evidence is very clear. This is about racism. First Nations populations had 5.9 times the rate of death from drug poisoning events in 2022. First Nations women died at 11.2 times the rate of their counterparts in BC in 2022. And in 2017 in BC, this is the last number we could find, Indigenous youth who use substances were 12.9 times more likely to have a fatal drug poisoning event than their non-Indigenous counterparts.
And switching over to the impact specifically on youth, for this topic, we're going to talk about youth under the age of 19, although we recognize there's different definitions of youth, including up to age of 25, sometimes even 30. So Lisa Lapointe, up until recently, our coroner in British Columbia, did a study specifically in regards to youth unregulated drug toxicity deaths in BC, and she found that from January 1st, 2017 to December 31st, 2022, there were 142 unregulated drug toxicity deaths in BC of persons younger than 19 years of age. I'd like to just briefly touch on the MCFD involvement. So of the youth who died from unregulated drug toxicity, 103 of them, 73% of those youth were in receipt of Ministry and Children and Family Development Services at some point in time. And we are going to touch a little bit again on the MCFD response to youth substance use and youth drug toxicity and overdoses. So regards to that MCFD number as well, this really, we're starting to sort of understand that MCFD involvement is becoming a contributing factor to developing problematic drug use. And so when we as a team actually look at vulnerabilities and factors in what makes a youth eligible for the team, we're now also looking at MCFD involvement. And that is our government care of youth who aren't being parented by their family. Lastly, the unregulated drug toxicity is the leading cause of death in British Columbia for persons aged 10 to 59, accounting for more deaths than homicides, suicides, accidents, and natural disease combined. And so when I look at this statistic, I often think of folks out there who are parents, in particular parents of younger folks who are approaching the teen years. And really, this is in British Columbia, this is now an everyone problem. This isn't a vulnerable street youth problem. You know, for people who have kids who are, you know, age 9, 10, 11, when you worry about things like suicide or, you know, motor vehicle accidents, cancer, it's actually drug toxicity that is the leading cause of death. And in regards to how we're dealing with it right now, it's not looking good. So just touching on intersectionalities, when we're looking at the kind of youth who we're working with in our field who are using substances, we do see a number of different intersectionalities. Those are folks who have additional vulnerabilities. Sometimes they may not fit the mold of sort of traditional substance use treatment models, and they just have massively additional complexities when working with youth who use substances. So again, we're looking at BIPOC youth, we're looking at MCFD involved youth, we're looking at LGBTQ2S+ youth, people living with mental health concerns, so concurrent mental health concerns, and that could be something that's pre-existing. That can also be something that's attached to their substance use. Seeing a lot of substance-induced psychosis coming on from methamphetamine use, for example. And then we're looking at youth who are unhoused or precariously housed. And we're going to touch a bit more on housing in the future, just in regards to that, the folks who aren't housed in the traditional family environment.
Okay, so how did we, as a team here in Victoria, start off? Sometimes we refer to as YT5. That's kind of how we started. It was Youth Tier 5 is what it stood for. But in 2019, the very beginning, like in the province, trends specifically kind of looking at drug poisoning events were improving generally. Kind of low. The things that we were doing in the general population seemed to be improving. That being said, youth substance use was still fairly unacknowledged. From that, however, our team kind of started. It started with a peer support worker, an RN, and a social worker that was actually Lorna. And by the end of that year, we had a full-time RN, BSW, MSW, a peer support worker, a nurse practitioner, that was myself, and a part-timer kind of consulting psychiatrist. We were one of, I think, 3 at the time, youth intensive case management teams in the province. And so there wasn't a lot that we could kind of rely on to kind of ground ourselves in standards and guidelines. And so there were a few things that we tried to create. So the first one is, the purpose of this team with a whole bunch of different disciplines is actually to work in an interdisciplinary model. So not multidisciplinary where my role ends here and your role starts there, but actually seamlessly trying to work together and function together so that young people, kind of don't see those abrupt stops or limits on discipline. So that's within nursing and medical and social work and psychiatry and outreach and peer support. The other thing is low barrier services, right? Like the majority of our work is outreach, even me. So the majority, I would say 90 to 95% plus of the visits that I'm doing as a primary care and addiction medicine provider is as outreach. And so physically meeting the youth where they're at, in addition to standing alongside them in terms of where their stage of change is, where they're at in that sense as well. We were trying to meet the needs along the full spectrum. And so when you're thinking about a team attached to healthcare, it's like medications and psychiatry. And so you're thinking about those things like, okay, they need to go to hospital, they're coming back out. But it's actually so much more than that. It's, talking to their lawyer, attending court with them, arranging, meetings with pulling different community resources together. It's talking and advocating about housing. It's the full spectrum from when that young person opens their eyes at the beginning of the day to when they're closed their eyes at the end of the day, all of those things in between.
So for folks who are interested in what our eligibility criteria is, that is, how do we decide who we work with? So our team accepts youth ages 12 to 19, and then we can work up to the age of 25. There's a little bit more to that, and we've kind of changed it throughout the years, but really what it is that if someone is over 19, we look at adult services for them. But when we take on a youth and they turn 19, we're not discharging them because they're turning 19. So a lot of different services, including, for example, MCFD, you see kind of that abrupt age out process at 19, and we want to hold on to the youth throughout those transitions. And then looking into the 19, 20, 21, if they still continue to need that high intensity service, we look at aging them into adult teams like adult ICMT, an ACT team, the CCOT team. And if they are doing a little bit better in regards to their substance use and where they're at with their goals, then we can look at stepping them down to a lower intensity service. We're working with youth who are regularly using high levels of usually illicit substances in the context of a poison drug supply in British Columbia. So the reality is that most of the youth on our team are using opioids daily and experiencing that regular withdrawal. But we also look at ages. So if you're looking at the younger population, sometimes we factor in things like problematic binge use. So a youth who may go out for 4 or 5 nights away from the home, use high levels of substances, opioids, meth, what have you, come home, crash, withdrawal, and then repeat. And so in those cases, we're not necessarily expecting daily use, but we're seeing that problematic use. Then we look at other circumstances, aggravating circumstances. So we look at marginalized populations, which we've already discussed. We look at unhoused and precariously housed youth, which is a high percentage of youth in foster care. So really we see this with, and this is through no fault of their own, but basically inadequate foster care resources. And we're seeing that because through MCFD, they really have a zero drug use policy in the foster resource. So there's really not much of an option for housing youth who use substances, and I'll talk a little bit more around that later. And also youth who aren't able to stay in the family home because of their substance use. Some parents have to do what I call Sophie's choice, which is kick out their older youth who's using substances if they have a younger youth in the home, because it becomes a protection issue. And so that's where we see a lot of that breakdown of the family home. MCFD involved youth. Criminal justice involvement, which is usually related to survival crime and drug use. And then we look at concurrent mental health, developmental disabilities, so FASD and youth living on the spectrum. We look at brain injuries, which are increasing because we're seeing our youth experiencing multiple brain injuries due to lack of oxygen from overdose events, and then other sort of behavioral factors that sometimes get categorized as medical or psychiatric, but can just be youth navigating their lives. Just a quick touch on developmental disabilities. We do work with youth who are living with FASD and who are on the spectrum. Adult ICMTs try not to. They try and refer those services over to CLBC, which doesn't do a great job of supporting the concurrent substance use youth as well. So that's a difference between the adult ICM team and the youth ICM team. And that can cause a little bit of difficulties when we're aging youth out at age 19 and into the adult services with CLBC. So there's just some complicating factors there. Youth who are exploited, so sexually exploited, gang exploitation, crime, that kind of thing. And we do a process called triage scoring when we're looking at the youth on our team. And one of the reasons that we do that is as the team got larger, as generally the case managers who are doing a lot of the intake and stuff, we had to kind of decide at what level we are accepting youth onto the team. And so we used an adult model of triage scoring, talking about vulnerabilities and where that places them sort of on a spectrum. And then we had to take the adult system of triage scoring and rejig it for youth because youth are different and their social situations are different when we're looking at vulnerabilities.
Yeah, so things that we realized we couldn't and now continue to realize can't rely on. So there's no youth act team. So for those of you that might not be, this was new learning to me when I came to the team. Really the difference between in the adult world, let's say, an ICMT or an ACT, assertive community treatment team, is really this kind of primary. So ICM teams look at folks who have a primary substance use disorder. It is a voluntary service. So that's because we know that that is how people respond best to that care. That's us, right? We need voluntary engagement. There's kind of more detailed specifics around how to engage in that way or what kind of supports or how frequently. But that is, a key piece to an ICMT is that voluntary component. The other one is an ACT team. Also, although a lot of adults who might be on ACT team might have severe substance use disorders, they have a primary psychiatric diagnosis such as schizophrenia, schizoaffective, bipolar 1, that kind of type. And there is typically an involuntary aspect. So they might be on extended leave, and there might be some conditions that they would have to engage with their team, which, as you can see at the very root, is quite different from our team. There were few other youth ICMTs, so we had to modify and kind of learn how to modify that from adult guidelines. Again, in the youth world, you can see that there's a whole bunch of different vulnerabilities. There's also a whole bunch of other people involved that we have to remain engaged and accountable to and for, and kind of all of these things. There are far fewer resources than adult systems. So no youth-based OPS or like safe consumption sites. So although some young people can sometimes attend adult-based OPSs or safe consumption sites, there is a lot, and I'll talk to this, there is a lot of kind of caution around that a youth can certainly sense. And certainly it's, it's different having an adult-based service versus a youth-based service. The next one is there's no housing for youth who actively use substances. So when we talk about the peak and the onset and, of fentanyl, for example, the peak is probably within kind of this 15-minute, depending on the route of ingestion, and it wears off fairly quickly. So that's usually when you see kind of folks using frequently in an hour or within a morning. And, we tend to see folks who have a really high tolerance start to feel some withdrawal symptoms in and around the 6-hour mark. That's getting more complicated because of adulterants. But certainly, as you can see, telling someone to go kind of like sleep it off or, don't use substances in your home can be challenging when you're starting to have physical triggers for use and also discomfort. There's no one in youth kind of specialized services that we're handing out harm reduction supplies, and we still continue to see some struggles in that. And so youth-based agencies where young people who use substances are engaging with frequently don't have or haven't always been handing out harm reduction supplies, and that sometimes it might just be a naloxone kit. There's no medical withdrawal management services outside of VGH. We're talking here in Victoria. And, in the fellowship, I've done a lot of work throughout kind of Victoria and the Vancouver area. And it is not really that common to see a medical withdrawal management outside of a more acute care service, like a hospital setting, which, as you can imagine, a lot of these young people may have been coming into hospital with a pretty traumatic experience. So to be asking them to go back to hospital when they're wanting a more recovery oriented goal, there can be some tension there. And the other thing is, here in Victoria, we don't have youth emergency shelters. So we do have, a youth emergency shelter, but again, there's some stipulations around use. And then also, there is some, we do have another service, but it is it's not all year long. Care providers feel uneasy with who use drugs. So when I came to this team as a prescriber, a fairly novice prescriber in 2019, I was able to kind of build some mentorship in, but it was quite clear that folks who were a steady hand in the adult prescribing role, and often kind of like renegades in that role, there was a lot of hesitation, and there still is a lot of hesitation when prescribing or working with young people. And that extends out to foster caregivers and sometimes even adult peers, right? We don't want young people to be in this adult space because we're worried about them. And that, kind of inherently that makes sense, although it kind of creates this continued isolated use of that youth are partaking in. Decriminalization changes don't extend to youth. So we see a lot of confiscation. We see a lot and the amounts don't matter, and a lot of criminalization with young people. And safer supply programs, like if you look at those protocols, none of them have a contraindication to use. So it's not to say that they're not for youth. And it's still kind of going back to that hesitation around prescribing to young people or care providing to young people that causes a lot of uneasiness and a lot of this social stigma that we put onto young people, that we shouldn't be providing them with a pharmaceutical grade. But of course, then the alternative is an adulterated substance.
And just a little update that you may not know about, but in regards to youth emergency shelters, they just got funding to extend the MAT shelter to all year round.
Right.
So yes, in Victoria, that's
Yes.
very new and exciting. So I'm just going to briefly touch on what happens when we work outside of a youth stage of change. So we kind of, for folks who work with people who use substances or know people who use substances, we kind of know that it doesn't really work to try and support someone outside of the stage of change that they're in. And so I find we tend to treat youth differently in regards to this. So something that I hear commonly, and I think a lot of us will say or think, is basically this youth is amazing. They're super resilient, super intelligent. They have so much potential. They just need to stop using substances. And youth hear this. And I think really what it says is all of these things, and then it's negated because you use substances. And so I sort of challenge that with, they're great and amazing, even with the substance use already. And so the other thing is that, this also puts shame on people who use substances and shame on youth. Youth don't need any more shame around using substances. They've grown up in a world where we treat people who use substances as lesser than. So they've already seen this. So they already know now that they're using substances that they're going to be treated like that as well, or that's the expectation. So there's already a lot of shame and stigma that's occurring. I think we tend to push youth more than adults to abstinence as being the ultimate goal. And so harm reduction can cause a little bit more discomfort in the youth world. But the reality is that these kids can't decide what they want to be when they grow up, where they want to be, what they want to be doing if they're dead. So we have to keep them alive in the meantime.
Okay, we wanted to run through a couple of examples of folks who are would be a very similar presentation of whom we might be working with and some situations that might be arising. So this example might be an 18-year-old female brown Hispanic youth using she, her pronouns. The background is they've been in MCFD care since they were 8. They lost a parent to overdose when they were 13. They currently lived in a staffed group foster resource, so meaning under MCFD care. Their first overdose due to a drug poisoning event was at age 15. And I'm not sure if some of you might remember a few years ago, there was kind of some thought that we might have an amendment to the Mental Health Act for minors who overdose despite not having who overdosed on opioids, despite not having kind of the traditional formable diagnosis like suicidality or homicidality. But the idea was that they would stay there for a week or so, gain some stability, be able to connect them to resources and maybe start on OAT. But for this young person, their experience was they were held and they would say, I know I'm not here for me, I'm here for them. Diagnosed with severe opioid and methamphetamine use disorder at age 16, using now IV. Their first episode of psychosis was at age 16, and since that time has had multiple involuntary hospitalizations under the Mental Health Act, and is now subsequently on extended leave. With a stipulation on that extended leave that she must engage with us. And because she's in MCFD care, that funding is of course brought to the foster resource. And so her income is basically zero. So she is, to gain substances, quite reliant on sexual exploitation. So the current concern is that she has a severe hand infection from perhaps an initial trauma from an injection site that we tried to treat with oral antibiotics. She didn't kind of engage with any of those oral doses. And now her hand is quite inflamed. It's coming all the way up her arm. She's feverish. She's requiring a medical hospitalization with prolonged IV use, and she's risking limb loss, sepsis, and death. And so despite having this, being under extended leave and kind of perhaps having a psychotic, having symptoms of psychosis, she's able to explain to you the repercussions of not having any treatment for this. And therefore, as you all know, under the Mental Health Act, she cannot be involuntarily brought in because it could only implement psychiatric care, not medical care. So that's what she would require. And so this is something that happens quite frequently with our team. And so this is what we really do is we rely and we lean really heavily on a longitudinal relationship where we've shown respect and we've shown care, and we've shown standing alongside them, so that when we say something, we say a concern, there's a hope that there might be some trust there. And so we try and facilitate as best we can a really supported entrance to hospital. So I'm calling over to the emergency room and speaking with that emergency team directly about what my concerns are. And so they don't have to repeat themselves when they come in. I'm also immediately calling the the addiction medicine consult team to be able to let them know what's going on. And so that way they can start treatment and basically just be waiting for them to enter so they can start to manage any kind of withdrawal and kind of keeping them comfortable and making some considerations for pain management. And then also we're accompanying them. We're either physically as the team or we're organizing somebody to be there when they go there and when they're being assessed. And then we're constantly checking in with that medical team throughout their hospitalization.
And another example of someone who we might be working with. So that would be a 17-year-old trans female, white, pronouns she, her. So background would be recently brought into MCFD care because both parents who are living separately are both experiencing their own mental health and substance use concerns. And so they're unable to currently parent. So she is brought into that MCFD care and into foster resource. Has a traumatic brain injury at age of 11, which is untreated and is really affecting some of her behaviors and the way that her brain works. She lost a best friend to drug poisoning event at the age of 15, and her friend was 15 as well. And she was present at the incident, and she identifies this as being the real turnaround moment for her when everything just kind of went downhill. Also diagnosed with a severe opioid and methamphetamine use disorder at age 15. She's smoking, has to smoke pretty consistently throughout the day to not feel dope sick. Again, she lives in a staffed group foster resource with 3 other vulnerable young people. Again, because living through that MCFD system and the foster resource gets the money to house, clothe, feed youth, they don't really get much of an allowance or any kind of income. And so again, reliant on that exploitation to obtain substances. And then, which we see with a lot of our youth who we work with under the age of 19, consistent missing persons reports. And so this brings me to things that our team considers and bumps up against is this consistent NPR reporting, which means MCFD has to have a policy, understandably, around if a youth is missing for a certain period of time, a vulnerable youth, that they have to call the person in missing. So for some of our young people, we will see 50, 60, 70 missing person reports throughout a year, and more even. And so this really puts us into a difficult spot because our team is usually heavily involved in this. We're the ones with boots on the ground who are also looking for the youth and updating those missing persons reports. And so we kind of get into this difficulty of it, the boy who cried wolf, like the police are getting tired of getting these multiple reports when they continue to just find the youth outside. But the primary concern for us is that that may be the case. And this youth is extremely vulnerable for trafficking, exploitation, death in isolation. And so we have to do this. So there's some tension around that. The other thing that we touch on is youth substance use and foster resources. And so more on that for the next slide. If you want to jump into that. That brings us to what are some of the most important things that we've learned working with the youth ICM team. So youth substance use can and does parallel adult substance use. That means we're seeing the same levels of substance use, the same tolerance levels, we're seeing the same withdrawal levels. It's not because they're younger, they use less or smaller amounts or aren't as affected. And we do often see not necessarily intentionally, but we can see under treatment of youth substance use for that reason. Our recovery pathways are medicalized and abstinence-based. We are behind the adult system in that one. Unless there's a duty to report, acknowledge privacy and confidentiality, we see in the youth world quite a bit more soft edges around confidentiality and privacy. And we understand there's duty to report. We understand we encourage family involvement and caregiver involvement. And we also work for a health authority, and our team needs to understand that there's medical privacy and confidentiality that's going on. Housing is a significant challenge. So I've kind of touched on this a number of times, but just briefly as I can. MCFD is not willing or able to house youth who use drugs. And this is not throwing anyone under the bus. We have some amazing foster resources out there. it's just not, the system isn't equipped. MCFD is not equipped to deal with a toxic and poison drug supply with youth who are using it. And so this is a huge systemic issue. So we'll see foster resources that have a zero tolerance for substance use. A youth has to check their bag at the door. If they appear to be under the influence, sometimes they'll have to sit outside until they get more straight. But then we also see foster resources on the other spectrum who are really trying to provide that harm reduction environment, but they're just not equipped to do it. And, it's really hard on staff. In the over 19s, we see supportive housing that is often low barrier. It has overdose prevention rooms in the space downstairs. You can go down and use. They'll have peer witness programs. There is nothing that exists for that under 19. So also, when a youth who uses drugs turns 19, they don't qualify for the MCFD age of majority programming. So MCFD is trying to roll out some age of majority programming for ages 19 to 27, where they can get some continued support, they can get some continued income, resources like education, work training, that kind of thing. And some of that can even be an extension of the foster resources. What we're seeing very clearly is that that does not qualify for people who are using high levels of substances. So they are still experiencing that abrupt age out system because the system has just not caught up. Which means we don't have places for youth to be monitored while they're using substances. We can't ask a youth who's using on the side of the road to go home and use because they can't use in their family home. Generally speaking, there are some family homes that do harm reduction with youth, but generally speaking, they can't use in the family home. There's no MCFD foster resource, there's no under 19 housing, and there's no youth overdose prevention sites.
So one of the key aspects that we have with youth ICMT that we've tried to remember is that we have some expertise in youth and substance use, and a youth is an expert in their lives and experience. And so, there are clearly things, as we said, like, we're regulated folks, so we do have to have, there's like some barriers and some boundaries on this. And the young person really guides how care is experienced, or how we kind of move through care with the team. So, as a prescriber, I talk about, let's say somebody's on methadone, we talk about like, what's the goal? Like, what are we looking for here? And then that's how we measure the success of that care. And so sometimes you think of methadone, we want them to stop using illicit substances, but perhaps they're just like, I don't want to have to hustle all day long. And I want to feel comfortable during the day. I want to be able to sleep at night and wake up feeling, some comfort, some ease, and not in total withdrawal.
And in regards to respecting the expert, just a couple sort of final thoughts on some of the things that we've learned from the youth who we work with. So one, I asked for a prior presentation what he wanted people who work with youth who use substances to know. And he said, don't pretend you know what it feels like to be dope sick, which I thought was a very fair comment. And touching back on that, even though not necessarily intentional, but our tendency to sort of undertreat youth who are dope sick, because our youth are using the same number of substances or the same levels of substances as adults, and if we do tend to undertreat that dope sickness, we work with youth who are pretty consistently dope sick all the time. And, that is a really uncomfortable feeling. It's awful. And so just really kind of sort of putting yourself in the shoes of youth who you're working with, oftentimes are opioid dope sick, coming off of methamphetamines, irritable, feeling really awful. And we're trying to, work with them and reach these goals. So just really trying to be kind and gentle around that situation. Don't assume that a youth uses less than an adult. Don't assume youth tolerance is lower, which we touched on. Include in a plan for working with the youth identified supports, for better, for worse. I just wanted to quickly say something about that because we do have to walk the line. We have to report any concerns that we have. We do encourage youth to have these, healthy relationships and healthy boundaries. And we see youth who may identify their primary person, their primary support, in some case, the love of their lives, as someone who we identify as not being a good person. And so we really have to walk the line of having these honest conversations with youth, but also accepting that this person is in their life, because otherwise we can push the youth farther underground. And that can include boyfriends and pimps and these uncomfortable things for us. And drop the assumptions around what treatment looks like. In the youth world, treatment is not just abstinence-based residential treatment. It's not just going on Sublocade and stopping opioid use. It's the whole harm reduction spectrum, just like it is for adults.
So what are some future considerations? First, I think, I hope that this is kind of quite clear, youth-specific housing for youth who use substances. And so, really acknowledging that young people experience withdrawal very, very, very quickly. And so, there are no spaces for young people to be. So that is quite critical that we've learned for the team. That is, housing is healthcare.
Mm-hmm.
Safer supply programs that include youth with ease. So there are safer supply programs. I recently, did a presentation on powdered fentanyl, and but we need to have some kind of ease of young people being brought into those systems. That harm reduction supplies are available at all youth sites. Again, this feels rudimentary, but it is actually quite key.
Mm-hmm.
So where young people hang out, they should have access to have some harm reduction supplies. Conversations about substance use in school, specifically in the youth curriculum, so something actually being built in about mandatory teaching about this. Recently, a What's New presentation by a nursing fellow last year likened this to sex ed, right? We know that young people engage in sexual activity, and we need to teach them safety and safer practices around that. That is the same thing with young people. It would be a dream to think that young people don't engage in substance use of all different types. And so we need to be providing them with that level of education. And then, of course, options for medical withdrawal management outside of the hospital setting. I know that there are places and communities that are starting to look into this, but really just acknowledging that that's critical. We need to be able to, support those recovery goals if they're desired in a setting that they haven't already perhaps received some or experienced some trauma.
That's the end of our presentation.